Good afternoon, everyone. I'll be narrating a twisted tale of a turned eye. Uh, it's not moving. Huh. A 52-year-old female patient came with a complaint of inward deviation of left eye since birth. She desired a cosmetic correction. So when we took up meticulous history, the inward deviation of left eye was since birth. It was non-progressive, non-resolving in nature. No history of diurnal variation was noted. No history of trauma was noted. No history of any previous ocular surgeries was noted. She was a non-diabetic, non-hypertensive patient, had no history of thyroid eye disease, and no history of usage of any high-power glasses. General physical and systemic examination was within normal limits. On ocular examination, head posture was normal. There was no head tilt or face turn which was noted. Right eye was orthotropic and left eye showed 70 prism diopters of esotropia in all 9 gazes on Krimsky test. Worth 4-dot test showed left suppression with no stereopsis. On ocular examination, right eye had BCVA of 20/20, and rest of the anterior and posterior segment examination was normal. She had an NS2 grade of cataract. Left eye, however, had a vision of 20/800 and a near vision of less than N36. She had NS1 grade of cataract. The fundus, as far as we could visualize, was normal, and the ocular movements were restricted. This was the condition wherein there was absolutely no abduction which was noted. Adduction was present but restricted. Basically all the gazes, there was restriction in all gazes. So we were thinking of, it looked like a strabismus fixus. It could be myopic strabismus fixus or maybe an post-LR palsy strabismus fixus. So the patient underwent MRI brain and orbit. And what we did find out was very surprising. She had on MRI scan, the LR muscle was shown to be absent. So this was a case of an absent LR muscle. However, we took an intraoperative confirmation of an absent muscle, and also on-table force duction test was done, which showed a tight MR. So moving on, a two-stage surgical procedure was planned, wherein first stage we did an MR hangback recession, and 2 months later, the patient underwent a vertical rectus transposition. A full tendon rectus transposition of superior and inferior rectus was done. This is the immediate post-op image. When we did a review of literature, very few articles are published on an isolated case of LR muscle absence. Many of the absence of LR muscle or any other muscle was associated with any craniosynostosis or craniofacial abnormalities, but very few articles mention isolated absence of the muscle. After 6 months, she had a minimal esotropia with abduction restriction. So what are my take-home messages? First of all, a congenital absence of a muscle is possible cause of a congenital concomitant strabismus, and this can be present even in absence of craniofacial abnormalities. So when we deal with such a case, we should keep this in mind. Secondly, the radiology has a very new emerging role in strabismus these days, wherein in case of concomitant strabismus, it helps us in looking into the condition of the muscle present. So in cases of a missed muscle, any muscle entrapment, any condition like thyroid orbitopathy, it can give us more information regarding the same, so it can help us in planning. Thank you.
Do you do dynamic MRI?
Yes, sir. We didn't do it in this case, but we can do a dynamic MR to see the...
So, have you heard of dynamic MRI? Anyone? The postgraduates? No? Never heard of it? Can you explain to them?
So basically, the muscle contraction is noted during the MRI procedure. So we can we can comment on contractility or
the thickness of the muscle is measured during abduction and during adduction of a given muscle. Usually it is done for lateral rectus or for medial rectus, not necessarily for the vertical recti. It's not very accurate. So ask the patient to look to the right and then look at the thickness of the muscle at the thickest part and look to the left and look at the muscle at the thickest part and compare it. It's very useful in some of these cases to do a dynamic MRI of the extraocular muscles. When you write for MRI, you must specify what exactly you want. Just don't write MRI brain, MRI extraocular muscle. What are you looking for in extraocular muscle MRI? Are you looking for restriction? You are looking for the absence of muscle? What are you looking for? That's important to specify. And if you have radiology in your own close by, you go and see during the procedure. It helps you to, the radiologist also feels comfortable that you are there. And the patient feels even more comfortable because you are there, although you are not a radiologist. Okay, good, well presented.
And it is an interesting case indeed. I have a similar patient. She has bilateral limitation of abduction. I have done her first stage surgery a month back with a large MR recession, but still there is not much improvement. So I have planned for transposition next month. Let's see. So it's an interesting case, and yes, I must congratulate your mentors. They have done a very good job.
Usually you see even in congenital absence of lateral rectus, when you isolate the area, you will see some fibrotic tissue.
Tissue, yes.
And you can just recess that, you can resect that fibrotic tissue and get some effect.
Effect, yes, sir. Zap.
Actually, congenital absence of lateral rectus is quite uncommon and has been rarely reported. I have come across cases of absence of inferior rectus that is
More
common.
commonly seen, more commonly
More commonly we have seen inferior rectus absence. Okay.